Good evening. Welcome everyone to today's Ophthall Surgical Video Club presentation. This is the Telegram group which you can see on the screen. You can join our Telegram group in case you want to ask queries further on. Second. Yeah, this is made possible by the imaging system by Ophthall Group. All the details are available on ophthalmod.com. Myself, I'm Dr. Mukul. I'm from KGF. I have my own hospital called Manjushree Hospital. I'm basically a cataract surgeon. So I take pleasure in inviting one of my teachers from MN Eye Hospital, Dr. Ravi Kumar sir, the founder and director of the RK Eye Hospital in Chennai. He has many roles in Chennai. So he's covering many hospitals, the Danish Mission Hospital, MN Eye Hospital, Red Hills, and also the MCOA Association Managing Committee member. So to say he's a fast surgeon will be an understatement because I have seen his surgeries. He's one of the fastest cataract surgeons, and he received an award regarding that in 2012, completed 160 surgeries in one single day, and recognized officially for completing more than 60,000 cataract surgeries in 2019. So obviously, sir attends a lot of conferences. In fact, as a faculty speaker, it takes great pleasure in inviting Ravi Kumar sir today. Sir, I will stop sharing my slides, sir. You can start sharing yours. Ravi Kumar sir.
Yes, you are sharing.
Sir, okay, I've stopped sharing, sir. Now you can start yours.
Okay. Is the PowerPoint is visible now?
No, sir. You have to share your screen first from the Zoom.
One second. One second. I'm sharing. Okay.
Yes, sir. Now we can see your desktop. You can open your presentation, sir.
Okay, 1 second. The bar is there.
It is there in the
audio is a little feeble. Like if you can come closer to the computer, I think it will be better.
Oh, now it is visible.
Yes, sir.
So now I can start. Now,
Yeah.
am I audible and visible? No.
Sir, yes, you can switch on your video also. We can see you.
Switch on, huh? Okay.
The video part.
Yeah.
Yes, sir. We can see you now.
Yeah. Thank you, Ophthall Surgical Club, for inviting me. Especially Dr. Sendil is one of my great well-wisher. And thank you, sir. And I'm really heartfully thank Dr. Mukul. Is one of my close and very favorite, one of my fellow and a very nice guy. And thanks for inviting me and for our nice words also. This presentation maybe is very useful for the beginners actually, because soft cataracts usually thinks that is very easy, but whatever the difficulties will come in the soft cataract management, the experienced surgeon can manage in a different way, but beginners will stuck. So because they'll take up the soft cataracts for the learning curve period, as think that is very easy, but some cases really stuck up, it will really gives a big trouble for you. So let me go into the presentation. So a few, what of my view and a lot of discussion can be shared to the beginners also. Okay. So trying to move, it's not moving.
Sir, you have to click the presentation, then it will move, sir. Yes, click it and then use the arrow.
Okay.
Yes.
So why it is important now? So because the people presenting with the early cataracts and cataract surgery have become a more of refractive surgery. The people are coming very early for the cataract surgery. And change of lifestyle and awareness brings the patient early for the cataract surgery. And most of the PSC, PSCC cataract and development cataract soft in consistency. And there we find the difficulty in managing the soft cataract also. So what are the challenges in soft cataract? So mainly we are used to practice the divide and conquer and shop techniques usually, and we'll learn that only as a routine practice. But these kind of techniques are very difficult to perform in soft cataract. And another challenge is most of the patients are young and highly demanding, so would be very perfect in our surgeries. And all soft cataracts are not the same. You should keep in mind. And the patients with the age less than 40 years have a consistency very gummy. And the patient come with the age of 50 to 60 years, the cataract is neither here or not there in consistency. In between, the surgery will go very difficult. So in coming to the management of soft cataract, these are the golden rules you keep in mind. The bigger rexes, good rhino dissection, good hydro delineation, if possible, and different strategies for different variants. These are golden rules you keep in mind when always will go for a cataract surgery management. So these are the techniques available. These are techniques are practiced by the senior surgeons and they are achieving very good results. So we can go by one. And a lot of different techniques also we will come over in the discussion with Dr. Mukul and the senior surgeons. So first, the thing is the carousel technique. So what is carousel technique? It is in soft cataracts. We have to, in this technique, we have to use the high vacuum. The flow rate should be high because the followability and holdability should be good. And the power is as low as 10 or even 5 also if possible in a mission. Good hydro delineation is very important. After the good hydro delineation, you are starting the surgery. You can see the video in the next part of the slide. So remove the epinucleus and debulk the nucleus in the center and catch all the edge of the nucleus and wheel it out of the bag as a carouseling. Okay. So you can see the nucleus rotating and easily goes to the probe and few minutes the surgery goes very well. So this is a carousel technique we can apply in most of the soft cataracts. If sometimes it is very difficult to do that also because it should hold the consistency of the cataract should be at that level, and also your holdability and followability it's so good, and then we'll be keeping the probe in a sideways in such a way it will go in a momentum, so that all things goes well. We can achieve this carousel technique. Would add any point in this, Dr. Mukul?
No, sir. I just wanted to ask in the carousel technique, the nucleus, do you bring it out of the bag with your phaco probe and then you start applying the vacuum so that it carousels, or in the bag itself you just carousel it?
You should make simultaneously. So you should hold the nucleus in one part, bring it out of the bag, and same time till nucleus fluently come out of the bag. That's one way you can do it also. Another way you keep it in there, bring it out of the bag, and also you can do it in any, because that type, no, if you bring it the nucleus out of the bag, you should have a good coating with the viscoelastic or the cornea with the endothelium safeguard. No, so that is also should be there. But both ways you can do it.
And next question is, if carousel doesn't work, sir, if it is
Yes.
not spinning, what is your
Yes.
next method? What will you do then?
Yeah, that is the following techniques, no?
Okay, sir.
It will come. Okay. So
Sure, sir. You can proceed to the next video, sir.
yes. Next one is a tilt and tumbling technique. Here, the larger lexis is must, that is more than 5 mm. Good hydro dissection. Here, what we will do, see, first I'm doing, you can see the video. First, I'm doing a good hydro dissection. Hold one pole of the neck where it is, have a good holdability. Hold it and with the nucleus probe, with the probe, and it should tilt it and then tumble with the second instrument. This is a tilt and tumble technique. If the nucleus size is, endonucleus size is lesser than your rexis, you can usually do this tilt and tumbling technique. So the other techniques, chip and flip, both the boards and hands and So chip and flip technique, where here you have to reduce the overall diameter of the nucleus so that the resistance at the richest margin is less. Here low power is used, high vacuum as usual. Here I'm seeing you can see I am chipping after the central core of the nucleus because basically debulking. So that because some nucleus, it's very deep, the resistance of the margin to bring out is very difficult. So you want to chip and debulk the nucleus at the center and then engage the anterior part where there is a good holdability is there, where you can hold it and flip out of the bag. This is the one technique we can follow it. Whether in case of if you are planning for a job and it doesn't happen, and then in between will stuck. So we can do this kind of technique like we have to reduce the overall diameter and also the core of the nucleus you can debulk. If both you do it, then you can easily bring out of the back. If you catch holding in one part of where you can put the holdability, there you hold and then bring out of the bag, flip out of the bag. This is called chip and flip technique. Most of the time we will do it. But one point I would bring it here is, here also I'm getting some, in this video you can see the wound, some wound burn is there. Because what I did is, I'm doing much more movement of the phaco probe and the edges, it touches, that wound dissipates and gives this kind of things. So you can avoid that also in kind of over enthusiastic, we keep on doing, so that time, you keep on moving the probe in the edges in the incision side and touches the edges frequently. That heat will cause this kind of wound burn also. We can avoid that also. These two techniques, tilt and tablet and chip and flip. If you have any points we can add.
Sure, sir. Any questions from our audience? If you want to ask, you can ask now or type in the chat. I'm not seeing any questions here, sir.
Okay, we can see.
Okay, sir. We'll proceed, sir. We'll have a discussion next week on next technique.
This technique is, most of them is very easier and very safer. So here we should have more than 5 mm rexis, that is 5 to 5.5 mm rexis, good rhydodissection and good rhydodelineation, prolapse the nucleus out of the bag, and after that coat the nucleus with the good viscoelastic above the nucleus and put under the endothelium, and use high vacuum and moderate flow and low power. You can do this supracapsular phacoemulsification. Here you can see I'm doing hydrodissection and also hydrodelineation. You can see the golden ring and gently prolapse out of the bag, and then doing slow chop and take with low power with the high vacuum and moderate flow rate. This is one of the safest technique. In also cataract, we can apply this one. I think most of the surgeons are following this only because it's very easier and safer also. Next one is the double Y groove technique. This technique is very, very interesting because in some case, here the nucleus really stuck to the capsular bag. The margin is very difficult to bring the nucleus out of the bag. Here it will stuck there. So what you do, even you do the trenches also, the heminucleus is very close to each other. It's very difficult to bring one heminucleus out of the bag also. So what you do here is Dr. Deepa Magar is wonderfully demonstrated in some presentation. So I followed it and did it. It's really working because what we are doing is we are making the both sides edges of the trenches as a Y shape. English letter Y, So double Y you make it, and then you can easily split, and then there is no friction between the two heminucleus. It easily splits, and then you can hold one anterior border of the nucleus, and the heminucleus is bring out of the bag, and then you can work on the resistance for the resist margin and emulsify the nucleus. So this Y groove technique also you can follow, because sometimes every surgeon will find this kind of difficulty, because here one point I can say that trench should be thin enough. One single thin trench is enough. Should not do bigger this thing. Again, if you do the bigger trenching, it will go as a bowel only. So single trench and widen the edges only of the trench, as a Y shape, and then you can split and can do this complete work phacoemulsification. It's clear,
Sir,
Mukul?
yes, sir.
Yes, yes.
The interesting technique, this double Y
Yes.
groove. We
Yeah.
have a question from the chat, sir. There,
Yes.
Dr. Shobana wants to know,
Yeah.
SKs are more often in the softer cataracts for me. How to avoid the corneal edema and the corneal damage, sir? How to avoid in softer cataracts? Because she's
So
yes.
it depends on how much phaco energy she is using. That is because you should keep the phaco energy as low as possible, because no need of phaco energy. Vacuum and flow rate is more essential. This thing. Maybe that area she can work on, and then she can avoid and use the more viscoelastics for safer guard for this, because the soft nucleus will easily come out and come out of the bag. Sometimes it hits the endothelium, will cause this kind of things. It's in my point of view. Mukul, what do you think? Anything you have had any points?
Sir, other than the power, sir, I think they should be conscious about your fluidics also. Because
Yeah,
the more manipulation you're doing, just because it's a soft cataract, doesn't mean you should keep rotating in the AC, touching the cornea here, touching the iris. The more minimal manipulation, you will have a much more clearer cornea the next day. So make sure the fluidics are also properly done. I think that also will help, sir. And one thing, another thing many people miss out is when you're everything they would have done fine, sir. When injecting IOL, they'll touch the cornea, and then they think they have used high power. That's why they got corneal edema. So any corneal touch will have next day you will have
yes.
corneal problems. So all steps has to be optimal. Only then you will have a next day clear cornea.
And also,
Next, yes, sir.
visco wash, complete visco
Yes,
wash
complete
is
visco wash.
that
Yes,
was a
sir.
little bit tarsal gas, corneal edema, and SKs also. Yeah.
Yes. Another question by Dr. Anusha Reddy.
Yeah.
She wants to know which technique to choose in what type of cataract. For example, PSCC soft cataract, which technique is best? Like anything like that, sir, you feel that subscapsular cataract, one technique is
Yeah, it's
best?
soft cutters are very tricky. So
Yes, sir.
what I try to say, only one technique is fits for any. It's not, you can't say that one technique fit for this kind of cataract, because we can't assess the real consistency of the soft cataract. It behaves in a different. In diabetic, it differs. Young patient is something will behave in a different way, and goes on your what do you call, doing the first trench and first chop, you can assess the consistency. Then you can fix up which technique will go for my good for my hands. Then you will decide and go for. I'm giving this spread of all these techniques. So you just think about that. So which way it's going on. So if it is able to chip, you can chip. If you can tilt and tumble. Or otherwise, you do this Y groove technique. And the following few techniques are there. You first, I think I'll say, good rexis and good ido dissection. These two, if you do it good way, then other things are goes well. Rexis should be in a good size, because minimum that is lesser than 5 mm, that is 4 to 4.5. Sometimes very difficult to pull off this kind of soft cataracts.
Thank you, sir. Another question: cortical soft cataracts, like when the hydrodelineation or the hydrodissection is difficult, then what will be the technique, sir? You have this cortical cataracts where hydrodissection is difficult, and then in that, what will be the best technique?
Dissection itself difficult move.
Difficult delineation, some cortical cataracts, sometimes the spread of the fluid wave you cannot assess properly and all that.
Yeah, that's what the chip and flip technique will work here. So you can do the chip, debulk the central core of the nucleus, and then you do a thin central trench. And then you can manually split it. It will happen. Or otherwise, hold the phaco tip on one side, and with the chopper or dialer other side, I can gently. You should not go to the deep of the thing. You can, if you do thin trenches towards both sides, if we do manually, it easily splits, because soft cutters doesn't have more resistance to split also. But its trench should be thin and deep.
So, and next question is, in the bag phaco, which technique chopping in soft is chopping in soft cataract? I think that's a difficult question. Can you chop soft cataract, sir? I think mechanical. I think your one more technique you will be showing.
Yeah, one more
But
technique. That is zero power technique. Here,
yes,
at least nucleus grade should be 1 or 2. 2 is 2. No, if it is 2, it is look like soft. No, that kind of no. You can do chopping. Chop. I'll show that video also if you will be more explanation. Will be more in that.
sure, sir. You can proceed. We'll just pull up the questions and we'll do one more discussion
Yeah.
next time.
Yeah. This is a question the doctor is asked. No, this is zero energy chop techniques. Here, the central groove is created at the central nucleus, and then hold the nucleus with adequate vacuum. There is no phaco power is used. If you use the phaco power, it will create a burrow. You lose the holdability. You hold with the adequate vacuum. Chop the nucleus with a sharp chopper. If it is confident enough, it is easily slices and then divide. You can practice in NS2, NS2 to NS3, this kind of this technique really works for me. So it is comes in experience. Zero energy chop technique is one of my favorite technique.
Yes, sir. Another question they're asking during trenching, how to
Yeah,
assess the depth? Any microscope illumination or modification you would suggest?
that you can
Assess the
answer.
trench depth.
That you can answer. You're
That
well versed in
question
the
is
microscope. Yeah. Yeah. That is illumination. No, you can see that coaxial. No, coaxial.
yes,
If
sir.
you keep it no correctly, you can get. You will have a very good this reflex will be very good visibility and better in nucleus. This kind of nucleus. Once you do, that's all the messing only. The glow with little go off. Otherwise, it is. It easily that the visibility is better in soft patterns. I don't think there's any problem in seeing that glow.
Yes, sir. The higher chances of punching the capsule in soft cataracts if they go too deep. So
Yeah,
I always try to trench deeper in the center and
yeah,
avoid shallow in the periphery.
yeah.
And I think soft cataract trenching itself is an art, according to me,
Correct,
without damaging the nucleus. You know, that soft nucleus. If you can make a like thin, small trench in the center and gradually go deeper, that comes with practice. What people sometimes, you know, it's easier to just prolapse the soft nucleus and just aspirate it off, sir. But
correct, correct.
you know, next time just try trenching with a low power thin trench, even in a
But
soft cataract.
low power should be there. Yeah.
Yes, so then you will get to assess how deep you can go. I think that will come with practice, sir.
Yes, yes, yes.
Sir, and next this thing, sir, we'll proceed.
Hello.
Yeah.
Yes, Prasad,
Uh,
please continue.
yes. Hi, Mukul. Can I ask a question?
Yes,
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 sure,
please.
sure.
Is it? Yes. Hello. Good evening, sir.
Yeah,
Sir,
good
very
evening.
nice video, sir. Thank you very much for like a brief explanation of all the techniques.
Yes, sir.
One thing I will say, I find difficulty to deal with the saucerization, sir. Like the bowl thing will happen, whole
Yes.
nucleus I'll eat off, and the bowl thing, that I
Yeah,
am finding difficult in some cases.
yeah.
How to deal with that thing, sir?
Yeah, it's bowl happening is even an experience as well. It will happen. So what the two points I can say, good trick. No, one thing is you do repeat the eyebrow dissection. Repeat the eyebrow dissection. Sometimes it works. It will really come out. Okay. Other thing, second thing I told no, this thin trench. You try it, thin trench. It will come. Then you can split and make a two energy nucleus and then bring it. These two techniques definitely works. I don't think the hydro dissection is one of the good secondary hydro dissection is one thing it will works. Mukul, you can say some other points on this.
Sir, okay, I have had many bowls actually, sir,
Yeah,
because soft cataracts, we all
every
have
surgeon,
that.
yes, yeah,
Yes.
every surgeon
So,
experience.
so the thing is, what I try to do is, since we are trained in SICS, you
Yes,
know how to prolapse the nucleus out of the bag.
yes.
So safely,
Manually
without
also,
damaging
manually
zonules,
also.
you can manually prolapse it out of the bag, because unless you're damaging the zonules, if you can avoid that, you can prolapse the epinucleus manually. Like sir said, hydrodissection. You can try visco-dissection also. Many times just
Yes.
visco-dissect, the epinucleus
So
folds and comes out this thing.
he,
And another thing, you know, many people don't do it. You try to extend your rexis also. Many times rexis will be small.
Yeah.
Take your time, extend the rexis. You make the rexis a little bit larger, and then you just hydro dissect. The whole thing just comes out. So the initially rexis might have been smaller. So I think these will be the points, sir. Anything extra, sir? You can cover.
Yeah. One point I want to add in this way, as the beginners, no, this bowel, like fear of this bowel, because sometimes all these messes, you lose the rexis margin also. We have to do iodization. So please stain the nucleus. There's even any premium kit, right? I'll do the stain because rexis should be visible till the end of the surgery. So do the Trypan blue staining, have a good eye on the rexis, good do the iodization, repeat iodization, definitely solve. Otherwise, it's not coming, the bulk is more. Do the central debulking again and again, and then do the iodization, it will come out easily.
Thank you, sir.
Okay, thank you, sir. Thank you very much.
Yeah, thank you. So go to the next video.
Yes, sir. Yes.
This is one technique I'll also practice because it's modified stop and chop technique. Here, what I'll do, you do a central groove and a central trench. Initiating the crack like a chopping, because in the stop and chop, what do a complete trench in a 2 width of rope and then go to the deep and then split. Here, what we will do the trench till you will keep little bit of mass at the edges of the both side of the trench, because we are good at chop, no? So what you do, go there, hold with the vacuum and then chop and separate and rotate again, chop and separate to make it 2 nucleus and then eat it up. This is called modified stop and chop technique. So this technique also, if you are good versed with the chop, you can do it, because sometimes you can very difficult to split this kind of soft cat, right? Now you can do chop, you can do really, you can do a good at chop, you can hold it good, hold it with a good vacuum and then place the chopper over the nucleus. It easily slices off and then split. You can do it. You can in NS2 kind of, not in NS1, NS2 and then more than soft cat, right? You can try this one.
Yes, sir. Please play the video, sir, in this one.
Yeah. See, I'm doing trenching. Both sides are repeatedly. Again, I'm doing the trench in other side and keeping the little part in the nucleus and then splitting one side and other side also. And the nucleus is holding the anterior part of the nucleus and bringing out of the back and then emulsifying it. Quickly, we can finish off this nucleus with the good control. Next one is, one of my senior surgeon is practicing this technique. It's called rapid. The name says, R stands for rotate the nucleus freely. A for align the phaco tip sideways. P for place the phaco tip at the nucleus rim. I for impale into the nucleus rim. D for devour and emulsify the nucleus. That this synonymous says the technique how to do it. You can repeat, remember the rapid. You can practice this also. It is one of the safer and easy to learn and very safer technique also.
Sir, this video, can you play again, sir? Because we're too short.
Yeah, sorry.
Yeah.
One second. See, freely rotating the nucleus. That's a very important point. And align the phaco tip sideways. Okay, keep the probe sideways. Place the phaco tip at the nuclear rim. Okay, impale into the nuclear rim. And then bring it out of the bag, emulsify it. That's all. This way. Okay, this is our rapid technique. You can try this also, because you can't plan it and do it. Sometimes it comes and works for me, but I've tried it, but it's sometimes works, sometimes I'll change my technique according to the consistency of cataract. So coming to this last side, see, take home message in the soft cataracts, because these cataracts are very tricky and the patients are highly demanding. So do perfect biometry. Preoperative evolution is very important. proper plan about the surgical technique, and perfect size of the capsule is very important. Good hydrodissation is a very important point to take into mind, and proper nucleus management in different techniques which is fit for you. And as you said, these patients are very demanding patient. They are always keeping a PCO protective measures in your mind. Okay. Thank you for kind attention.
Sir, like your surgeries, you have finished very fast, sir. Everything. So, questions. One more question we are having now. During hydrodissection, when
Yeah.
one pole prolapses, can we flip and chip, or should we sculpt? In older patients, the nucleus is a big to flip. So, if the nucleus is big to flip, sir, then what will be the thing? That's the
See,
question.
if the rexis margin is good enough to flip, you can flip. Otherwise, put it back, do the trench, debulk, and then try your hydrodissation again and bring it out. So it depends on the rexis margin. It goes hands in hands. How much of the rexis size we have and the nucleus size. Assess the nucleus and then decide which is goes for you.
Any other questions by our participants here? Lalit sir has joined. Sir, are you there?
Welcome, Lalit.
Yes, sir. That was a wonderful presentation.
Thank
Dr.
you,
Ravi Kumar sir
Lalit.
is a good friend.
Yeah.
Okay.
Very, very good friend. So we generally travel to conferences and all together.
Yeah.
Wonderful surgeon, very quick surgeon, very nice surgeon. And this presentation was really nice.
Thank you from your words. It's really soothing me. Thank you, Lalit. So nice of you.
I think we have got a lot of new people who have joined today, so they can introduce themselves or even ask some questions. Whoever has joined for the first time.
Let me see, sir. Anyone willing?
You can at least introduce yourself, like Dr. Beulah, Dr. Jayashree, Dr. Prasad, I think has been.
Yes, sir.
Dr. Gangadharan. I think Dr. Ravi Kumar attracts a lot of people. Today we have got good numbers.
Thank you, sir. All our friends now encouraging us, they are coming.
So any questions from the audience? Or if anybody wants to comment, or if you want to be a part of the next session, you can contact Dr. Mukul also.
Definitely.
Any other surgeries you want to show, sir? Like Dr. Ravi, if you want to show. We have another 10 minutes.
This is a clips are edited and keep, otherwise it will go for another 5 hours.
We can discuss even a lot more, sir.
Yeah,
Sir, one more, just last point I wanted to ask. Have you experienced capsular blowout, sir? Because in the soft cataract, many times we are very aggressive with our hydrodissection.
Hydrodissection, yeah.
So, blowout, have you faced, sir?
So for me, blowout is usually hydrodissection will be very careful. For me, it's really a nightmare. Hopefully it don't happen to me. So
See,
far,
one small tip is just to add to Dr.
Yes.
Ravi said.
Yes.
Instead of using a 5 cc syringe, or you can use a 2 cc syringe for your hydro.
Good point.
So the amount of fluid which you're going to inject is going to be minimal. See, I see a lot of people using a 5 cc syringe. So all this can happen, especially small rexes, bulky nucleus. Soft cataract generally going into a blowout is very rare. It's only a bulky nucleus with a small rexis you can have a blowout. And to prevent that also, you can use a 2 cc syringe, which will, reduce the chance of a blowout.
Good control also would be there, correct, sir. Smooth and very good control, yes, sir. And also to check before that how much flow is coming, So syringe consistency, the flow, sometimes the syringe is very tight. We don't know. So how much flow is coming. Please check everything. Then go.
Yes.
There is a solution for that also. You start using BD syringes.
Yes, sir.
So BD syringes work like magic. So I've totally shifted to BD syringes. It's a little expensive. Maybe it's like 3 times or 4 times more. But these are critical steps.
What is that, sir?
So I've started using BD 2 cc syringes for this hydrodissection and all.
Okay.
There is absolutely no jerk. It is very smooth.
Okay. Very nice. So, Lalit sir, what your good hold technique and soft cataract? So all these varieties are there. So all premium surgeries are doing. Most of the young patient are operating. premium toric and everything. So what is what do you think that which is the most safer technique in your hands? That is, sir, it's audible for you.
Sir is muted.
Oh, sorry, it's muted. Sir, Lalit,
I think maybe he's
I
not.
think he's gone to see the patient again.
We have Dr. Armuganainar from Viluppuram. Sir, any comments from your side, sir?
Welcome, Argunena, sir.
So maybe they're all in the OP.
Yeah, just
And,
maybe they're following our presentation. But
yeah.
maybe
No, sir. Because what is that the BD syringe? What is special about that BD syringe?
so it is. I got to ask Lalit only, but what he is saying is it is smooth. It seems that injection be
No,
very.
no, not smooth. I think
Uh,
he was saying that we can use 4 or 5 times like that. He was telling.
oh,
I
I
don't
don't know,
know.
sir. Just I want to try to ask. He is muted, sir. Let me find it out and put it in the group, sir.
Uh, Ravi Kumar, can I just pass a comment about BD?
Yes, sir. Please, sir. Welcome,
So
sir.
it stands for Bennett and Dixon. They are
Okay,
a
sir.
very nice old syringe makers, and their 30 gauge syringes are amazing.
Okay,
And
sir.
needles are also very, very amazing. They are specialists in needles as well as syringes. I think we import them into India.
Okay.
So very nicely made and very precise. So they don't get stuck, and you'll get a smooth flow.
Smooth flow. Okay, sir. Okay, sir.
BD, capital B, capital D, Bennett and
Yeah,
Dixon.
yeah.
Oh, okay.
Dr. Mukul, I think we got the next speaker. We can ask Dr. Ramesh Dharirajan sir to take the session next time.
Hopefully, sir should accept, sir.
Sendil,
Sir,
I feel no, this is the era for the next generation. The old people should quietly listen and not talk.
no, we have a mix of seniors and juniors. So it's always the juniors also want to learn from the seniors. So it's like a mix.
Sendil, two comments about soft cataract. I missed the initial 20 minutes. I'm
Oh,
sure Ravi has covered it. But
yes.
personally, I feel a good initial hydro dissection and to rotate the entire new cataract several times is very important. Second thing is, if you can do a second hydro delineation, a two-step hydro, it makes it so much more easier to remove.
Yes, sir.
If
Correct,
you
sir.
fail after these two, sometimes I will do visco. I'll inject visco and I will separate the epinuclear shell away from the capsule. So that is once in a while. Nucleus is removed, but the epinucleus is not coming out. In that
Okay.
case, I will displace it by putting visco again between the capsule and the epinucleus.
Okay.
That's all.
Okay, sir.
Any comments from the juniors? Like,
Okay. Sendil, sir, any words from you, sir, before we close our session today?
no, I think this initiative has been going on well. This is the 9th or 10th session.
9th, sir.
Okay, so next is the 10th. So we do it twice every month, and we are on the 5th month of this. And thanks to Dr. Mukul for continuously supporting and being doing it. And I think slowly the momentum is building. It is getting a lot of interest from the people. As Dr. Mukul said, more than the people who attend live, there are so many people who look into our YouTube channel. And I think
You are sharing the link anywhere, sir, to
yeah, it will be in our Ophthall and
share with
Dr.
my friends
Mukul.
and all?
Yeah, we have it in both the channels, sir. We will update it in 1 or 2 days and then we will put it. So, and I think Dr. Ramesh has been commenting about my book. So, if any of you have not yet purchased the book, request you to buy the book and give your valuable feedback. And
You can give it as a presentation, present for all the presenters also.
Yes, sir. Yes, sir. For the speakers, definitely.
Actually, I bought it, sir. Don't worry, sir. I give it to my wife. I give it to my wife.
No,
You give it.
no, no. Even all the conference also we want to give it, because rather than giving mementos, today I was thinking. In fact, thanks, Dr. Ravi, for bringing it out. For all our speakers who are in our sessions, we will be definitely giving. And thank you for. And I am looking forward. It's my first experience of writing a book, so need all your valuable suggestions. And if there is an encouragement, I will continue writing more books. And it's been very good. It already became an Amazon bestseller, and almost close to 1,000 copies. So hopefully we will reach 10,000 also. Thanks to all the support. And I think, Dr. Mukul, if there are no other questions, I think we can close up today's session. And,
Yes, sir.
let
Thank
us
you.
have-
Thank you, Ravi Kumar, sir. From your busy OPD, you have taken time to explain beautiful sessions.
My pleasure. My pleasure. In the
And thanks to all doctors who participated, especially from Tamil Nadu also. We had a good representation today. Yeah.
Okay,
Thank
sir.
you.
We'll end the meeting here, sir. Thank you. Thank you, everyone. Have a very good evening.
Thank you. Thank you so much. Thank you so much. Thank you, Mukul.
Thank you, sir.
Thank you. Thank you. We'll keep in touch. We'll call you later.
Yes, sir. Yes, sir.